This is the lecture on caring for the patient who has a complex respiratory disorder. This will be your third lecture when it comes to respiratory. We've already done upper and we've already done lower. Now let's talk about some more complex respiratory disorders, things like respiratory failure. We're going to look at pulmonary edema. We'll look at acute respiratory distress syndrome and acute lung injury. And then we'll conclude by talking about patients who are going to be put on ventilators, some implications for ventilators, intubation, and talk about what do you do as a nurse when you have patients on these ventilators. So let's talk about these in the next few slides. In order to understand respiratory disorders, especially the complex respiratory disorders, you need to go back and review your respiratory physiology. So you want to go back and look at how the respiratory system works. And I posted a really good video, kind of a long video, but a video in your course that'll help you go back and review the respiratory physiology. Remember, there are different parts of the respiratory system when it comes to oxygen exchange. There's the acinus, which is that terminal respiratory unit. That's the big component that actually houses all the structures all the way from the bronchiole to the alveoli. Then there's the alveoli, which are those little air-filled sacs that prevent fluid from filling the spaces in our lungs that should have air and help promote gas exchange, so the absorption of oxygen and the disposal of the CO2. And then finally, one of our central components of gas exchange is that alveolar capillary membrane. This is actually the membrane that permits gas exchange. It helps regulate the flux of fluid and solute between the alveoli, the interstitium, and the blood. And it helps promote fluid clearance from the alveolar lumen. If these are all foreign concepts to you, again, go back and review the respiratory physiology so you can remember exactly how the respiratory system works. It'll make understanding complex respiratory disorders a lot easier for you. In your anatomy class or your pathophysiology class, you may have heard of something called the oxyhemoglobin dissociation curve. And basically, we know that how our body functions related to oxygen relies heavily on how the body carries and releases oxygen. And the oxyhemoglobin dissociation curve is a tool that will help us explain how the blood carries and releases oxygen. And it's actually showing the percentage of oxygen saturation, which we know is SaO2, at different oxygen pressures, which is that PaO2. And what you're really looking for is what on this curve is hemoglobin's affinity for oxygen. And what affinity simply means is how readily the hemoglobin in the blood will acquire and release oxygen molecules from its surrounding tissues. You can look at the curve and see that the higher the PaO2 pressure, the more oxygen saturation you get, until you get to about 60. And then you notice that it just kind of levels off. So up until about 60, the higher the PaO2 pressure, the more oxygen saturation you get. Now you're going to see that there's little dots to the right and little dots to the left. And that's what we call shifting to the left or shifting to the right. And those shifts are going to be directly related to the body's need for oxygen or the body's demand for oxygen. If the shift is to the right, what's happening is the hemoglobin has less affinity for oxygen, which means it actually releases it easier. So let's think of conditions where the body would need the oxygen to be released more readily. And that would be in situations where we have increased carbon dioxide, decreased pH. You've got to think back to your ABGs. Okay? So increased carbon dioxide, decreased pH, and hyperthermia. So we're talking about heat, we're talking about acidosis, and we're talking about exercise. Those are three areas where the body would want the hemoglobin to release the oxygen more readily. On the opposite side, if we're shifting to the left, this means that it's more difficult for the hemoglobin to release the oxygen to the tissues. So you can see on here, that would be a decrease in the PaCO2, a decrease in temperature, or hypothermia, or an increased pH. And this can be kind of confusing as far as the shifting to the right or the shifting to the left. I did post a very short, about 8-minute video that explains the oxygen or oxyhemoglobin dissociation curve, just for you to review so you can kind of get an idea of what it does mean. You probably will hear shift to the left or shift to the right when you're in practice, and just kind of understanding what's going on will help you understand patient care a lot better. I also want to bring up shunts just so that you have been exposed to the terminology. We know just by definition that a shunt means that something is bypassing another. So, for example, in pulmonary, a shunt can be anatomic or physiologic. If we're talking about an anatomic shunt, that's when blood is bypassing the lungs. Maybe it's through an open channel in the left and right ventricles, meaning we've got some kind of a defect in the ventricles of the heart. Or it could be a pulmonary anomaly, meaning that we've got something that's not functioning correctly or hasn't been structured correctly, where blood is actually flowing directly from a pulmonary artery to a pulmonary vein and not going through the lungs like it's supposed to. So the blood is being shunted around the lungs in an abnormal way. That would be an anatomic shunt when it comes to the pulmonary system. Now, physiologic shunt in the pulmonary system is when the blood actually goes through the regular pulmonary vasculature, so it's actually getting to the lungs, but it doesn't come into contact with the air in the alveoli. So rather than having a defect like we did in the anatomic shunt where the blood completely bypasses the lungs, with the physiologic it goes through the pulmonary vasculature, but it's not coming into contact with the actual air in the alveoli, which we know if the blood's not coming into contact with the air in the alveoli, we're not going to get the perfusion like we should. Sometimes we'll get physiologic shunts whenever we've got conditions like pulmonary edema or pneumonia or atelectasis, which was that collapsing of the segment of the lung where the alveoli are filled with fluid or collapsed. Two other terms we want to talk about that are very important to our respiratory status and our oxygenation in our body are ventilation and perfusion. Ventilation is the amount of inhaled air that actually gets to the alveoli, whereas perfusion is the amount of blood that reaches the alveoli. If you're in the hospital, you may hear the term what they call VQ scanning, and that's actually going in and looking to see how much ventilation and perfusion the patient has. Now, ventilation is represented by the V, but the perfusion is going to be represented by the letter Q, which is why you hear it called VQ scanning. Ideally, we want to have our ventilation and perfusion at a ratio of 1. We hope that our ventilation and our perfusion are equal. Because we know that we have to have an adequate amount of blood in addition to an adequate amount of air to actually have good gas exchange. Whenever we don't have a ratio that's close to 1, and it can vary maybe down to a 0.8, but when we get it off balance, we call that ventilation perfusion mismatching, or VQ mismatching. And it's this mismatching that is a very common cause of acute respiratory failure. So what do we mean by mismatching? If you look in the diagram in the upper left hand, or A, a normal unit, if you think about the ball, looks like a Christmas ball, that's your alveoli. Okay, that's what fills up with air. If you look below that, you'll see a little line that's red and blue. That's going to be your blood flow. So in a normal one, you see that the unoxygenated blood, represented by blue, comes in. It wraps around that air-filled alveoli. So we've got normal air going in and normal blood flow. There's a gas exchange that's happening, and we can see that our blood flow leaving is red, which means it's oxygenated. So that's our 1-to-1 or nearly 1-to-1 ratio in normal. If you look at B, we call this a dead space unit. What do you notice that's different? Well, we notice that there's no color where the blood should be coming through. So this lets you know that a dead space unit is where the alveoli still has air, but we're not getting blood flow. Now, we may have a little tiny bit, but for right now, we've got a mismatch. We've got more ventilation than we do perfusion. And we're going to talk about disorders that kind of go into this, but some of the examples might be a pulmonary embolus or cardiogenic shock. Okay? Think about an embolus. It blocks off the blood flow, so we're not getting any blood flow to the lungs. Also, cardiogenic shock, which is actually derived from hypovolemic shock. So if we're extremely hypovolemic, we don't have enough blood flow to get to the lungs, we can go into this dead space unit, this mismatch. So then let's look at C. How does that look different to you? This is what they call a shunt unit. We see a nice thick line of blue, which means we're getting blood through there, it's unoxygenated blood, but look at the alveoli. It's collapsed. If the alveoli is collapsed, it's not getting the air that it needs. So you'll notice that the blood that's leaving is not red, it's still blue. There's been no gas exchange. Okay, so In this case, we're getting adequate perfusion, but we're just not getting the ventilation. And then the last one kind of combines everything. This is called a silent unit. Notice we're not getting air and we're not getting blood. And as you can imagine, any kind of a mismatch can be a problem, but when we get down to the silent unit, we're not getting any ventilation or perfusion. And these are some components that kind of help you when we start talking about respiratory failure and the complex respiratory disorders. All right, let's start a discussion about different complex respiratory disorders with acute respiratory failure. Okay, ARF. If you ever hear ARF, don't get it confused with acute renal failure. When we're talking about acute respiratory failure, we have two different types. We have hypoxic respiratory failure and hypercarbic respiratory failure. And as you can tell by the terminology, hypoxic respiratory failure results from hypoxemia. So hypoxemia means that we've got an arterial oxygen tension or pressure that's below our normal range. So we've got a normal PaO2 between 80 and 100. If we've got it below that level, like a PaO2 of less than 60, and an arterial saturation of less than 90% on room air, we start going into hypoxemic respiratory failure. So let's briefly think about what are some situations that could cause your patient to go hypoxic and have hypoxic respiratory failure. One of the most common things you might see, you hear people that travel to, for example, Colorado or higher elevations. Okay? They go to a high altitude and there's less oxygen that's available in the air. If there's less oxygen available in the air, we can't absorb it or we can't breathe in the concentrations that our body's used to, and it can make us go hypoxic. We could have that VQ or that ventilation perfusion mismatch. That could be in something like an airway disease like asthma or COPD, bronchitis. We could have an interstitial lung disease or a disease where we have a problem with the vasculature or the blood flow through the pulmonary system. Things like we talked about a pulmonary embolus or pulmonary hypertension. Another thing we might have, an anatomic shunt. Maybe there's a defect, maybe a cardiac septal defect or a problem with the alveoli in the lungs where we've got the blood not going where it needs to go. We might also just have hypoventilation. Think about what would cause hypoventilation. You could have a patient that's coming out of anesthesia and is still very sleepy and is not breathing as fast as they need to. We also could have a diffusion impairment, meaning we've got something like an interstitial lung disease where there's not an actual absorption like there needs to be. Anything that causes that oxygen level to go down in the blood can result in a hypoxic respiratory failure. Okay, so now looking at it from a different perspective, rather than talking about oxygen levels that are below normal range, we can talk about hypercarbic respiratory failure. And in hypercarbic, also called hypercapnia or hypercarbia, the concentration of CO2 is above normal range. So we're not really looking at oxygen here, we're looking at the CO2. And if you remember that normal PaCO2 is between 35 and 45. Okay, so some causes that might cause us to have increased levels of CO2 in the blood, well, they usually all relate directly back to hypoventilation or not breathing effectively because our CO2 levels go up because we're not exhaling them adequately. So let's think back again to what could cause us to have hypoventilation. It could be a depressed respiratory drive. It could be obesity or that sleep apnea. It could be COPD. We could have an abnormal chest wall, maybe some kind of trauma or something that's not adequately allowing us to breathe like we normally would. We could have a neuromuscular disease that's causing us anything that can cause us to not effectively breathe in and breathe out. Because not only do we have to get the oxygen in, we've got to blow out the CO2. When assessing our patient for respiratory failure, some of the clinical manifestations we're going to see include a cough, sputum, and rales. And most of the time, your cough, sputum, and rales are usually related to the underlying cause of the respiratory failure. But your presenting symptom in respiratory failure, regardless of the cause of it, is usually shortness of breath and tachypnea. Okay? You also want to pay special attention to the neurological function of your patient. Remember that whether it's a decrease in oxygenation or an increase in CO2, it's going to affect the neurological function of your patient. Okay, it's going to affect their level of consciousness. It can lead to them getting very fatigued. And we know that when you get super sleepy and you get fatigued, it can eventually lead to respiratory arrest. So oftentimes we'll call this state somnolence. You may have heard that term before. So when it comes to respiratory failure, it might not be uncommon to see blood pressure go up just a little bit. Maybe we've got some anxiety going on. The body's trying to shunt the blood to get oxygenation where it needs to go. It's not uncommon to see your oxygen saturation dropping a little bit because we know that part of respiratory failure would be decreased oxygenation. It's not uncommon for the patient to feel weak. They're struggling to breathe and they're breathing fast. But it's when you start seeing your patient go into that somnolent state or that almost inability to arouse your patient. They're just so sleepy and you're trying to arouse them up and they just keep wanting to fall asleep. That's the time you want to really step up and call the doctor. Because when they get to this point, we are pending respiratory arrest. Not just respiratory failure, but respiratory arrest. And we know that's a full-blown code. If we're talking specifically about hypoxemic respiratory failure, remember again we're relating back to the decreased levels of oxygen in the blood. So we'll start seeing things like cyanosis or central cyanosis. You might see the capillary refills flowing down. You might see blue fingernails. The central cyanosis means we're going into more of a respiratory failure mode. And where do we see central cyanosis? We see it around the mouth. We see it on the mucous membrane. Okay, that would be an indicator of acute respiratory failure. On the other side, hypercapnic was that increased levels of CO2 in the bloodstream because we're not breathing it off effectively. So we're going to actually see acidosis in these folks. And if you think back to your ABGs, one of the side effects of acidosis was that muscle twitching. And it's also the hypercapnic patients that are going to be more likely to not handle the respiratory failure or not handle the high levels of CO2 as well as those that are having hypoxemic. They're the ones that are going to usually become sleepy, become somnolent, and they're the ones that are going to go into that decreased level of consciousness a lot faster than our hypoxemic patients. When it comes to diagnosing respiratory failure, we're going to get ABGs. Remember we said one of them is directly related to oxygen, those related to CO2, and we know that the best way to get an accurate reading of those is through an arterial blood gas, and you can see them doing that in this picture. We're going to get a thorough patient history. What's been going on with the patient recently? What other factors do they have that could preclude respiratory failure? For example, did they just recently have surgery? Maybe we're talking about a pulmonary embolus that's traveled to the lungs and is cutting off blood flow that could lead to respiratory failure. We're going to do a complete physical assessment to look for those clinical manifestations, that cough, that sputum, that shortness of breath, the tachycardia. Okay. Other tests that we could use, a chest x-ray or a CT scan or an MRI. And with those, they're looking for possible causes for the respiratory failure, things like pulmonary edema, pneumonia, heart failure, asthma, maybe cancers in the lungs. So we have to use a combination of things to determine if it's respiratory failure and what our causes are, because our cause is going to lead to how we treat it. When it comes to medical management of acute respiratory failure, there's a wide variety of things that are going to be done. But our management goals are going to relate back to correcting hypoxemia. So whatever's causing our patient to be hypoxic, we want to try to correct that. We also want to make sure that supplemental oxygen should be given until we can figure out exactly what's causing the hypoxemia. In the event that we give supplemental oxygen to the patient and the patient does not respond to that supplemental oxygen, it's going to be necessary for us to anticipate that they're going to be intubated. So we want to prepare for endotracheal intubation. And it's important that the nurse understands the concepts behind intubation and artificial ventilation. And we'll talk about that in some later slides. But it's really important once you put the oxygen on your patient that you really go back and evaluate to see if the hypoxemia is actually being treated and it's getting any better. If not, they're going to be intubated. We want to improve life-threatening acidosis, so we'll take measures to help with acidosis. We want to maintain or improve cardiac output, so we need to look at what's causing our problems with our cardiac output. Is it hypovolemia, meaning that we need fluid resuscitation? Is it the heart itself is not functioning correctly? Do we need medications to increase cardiac output? But again, we're looking for and identifying and treating that underlying cause and hopefully avoiding complications related to this respiratory failure. Now let's move on to acute pulmonary edema. And you've probably heard us talk about pulmonary edema when we talked about respiratory disorders, and you're definitely going to hear it again when we talk about cardiac disorders in the next med-surg course. But when we're talking about pulmonary edema, we're talking about an abnormal accumulation of fluid in the lungs. Well, we know that lungs are supposed to have some amounts of fluid, but not too much. And when we get too much in the lungs, it can lead to respiratory failure. Okay. There's two different types of pulmonary edema. There's cardiogenic, and just by the word cardiogenic, we know genic means beginning, cardio means heart. So this is pulmonary edema that's linked back to the heart. And then there's non-cardiogenic, which means it's not linked back to heart. When we're talking about cardiogenic pulmonary edema, or CPE, we have to think that usually it links back to some type of a heart failure. And heart failure is the fastest growing cardiac disease in the United States right now. And about 5 to 10% of our heart failure patients will eventually develop cardiogenic pulmonary edema. So we can tell that we really need to start going back to the basis of pulmonary edema when it comes to cardiogenic pulmonary edema and looking at our heart failure patients. And if we can prevent the heart failure, hopefully we can prevent the pulmonary edema from forming. Let's take a brief look at some of the etiologies or the causes of acute pulmonary edema. First thing we said was CPE, or cardiogenic pulmonary edema. This usually happens because of a left ventricular pump failure. The heart doesn't have the ability to pump the blood effectively, so the body builds up fluid around the lungs, causing pulmonary edema. Non-cardiogenic pulmonary edema can be caused by adult respiratory distress syndrome, which we're going to talk about later on in the lecture, or acute lung injury, which again we'll talk about later in the lecture. We can also get neurogenic pulmonary edema, which would be a type of non-cardiogenic. This would be maybe as a direct insult to the central nervous system. We can get negative pressure pulmonary edema, which would be where a patient is trying to breathe or ventilate against an airway obstruction. We can get high altitude pulmonary edema. This would be because of low atmospheric pressures and low oxygen content at those high altitudes. So when somebody develops high altitude pulmonary edema, maybe they went for a skiing trip and they're not used to those high altitudes in Colorado. We can have heroin induced, and this will usually happen within the first 24 hours after the administration of heroin, and usually happens within the first several hours after they actually inject the heroin. And with the heroin-induced pulmonary edema, we're not exactly sure why it causes pulmonary edema, but they're thinking it's some type of a direct or indirect injury to the alveolar capillary membrane. We can get pulmonary edema from excessive IV fluid administration. We get hypervolemic. When we have too much blood volume, the fluid's going to leak out into the interstitial spaces, and those interstitial spaces can be in the lungs until we get fluid buildup in the lungs. We can get transfusion-related lung injuries. And finally, we can have toxic and drug-related pulmonary edema, where it could be caused by an inhalant or an oral parenteral toxin. If it was an inhalant, it's because it caused direct injury to the lung. Also, orally or parenterally administered drugs, they can lead to pulmonary edema because they alter the clearance of fluids in the lungs. And I don't expect you to remember all the different kinds, but just keep in mind that pulmonary edema can be caused by a lot of different things. It could be cardiogenic or directly linked to the heart, or if it's non-cardiogenic, there's a whole laundry list of other things that can cause pulmonary edema. So when we're talking about treatment for pulmonary edema, we're definitely going to be looking at the causative factor in determining how we're going to treat this. And we'll talk about treatment in the next slide. So when we start thinking about how we're going to treat pulmonary edema, it's first important to understand the pathophysiology of what's actually going on. Again, if we're talking about cardiogenic, we're talking about left ventricular pump failure, which leads to increased left ventricular filling pressures, which leads to increased pulmonary pressures, which actually leads to a fluid buildup around the lungs. Now, this can be caused by a systolic, a diastolic, a valve dysfunction, or it could be pericardial tamponade. And pericardial tamponade will be talked more about when you get into 4100 or med-surg 2. But basically what this is where we get like an accumulation of fluid or pus that builds up in the pericardial sac around the heart. That's that sac that surrounds the heart. And if we get excessive fluid or pus that builds up in that sac, it causes pressure on the heart and makes it where the heart can't pump effectively. So anything that could cause the heart not to pump effectively can lead to this pulmonary edema, this cardiogenic pulmonary edema. On the other side, when we're talking about non-cardiogenic pulmonary edema, we're talking about something that's caused increased capillary permeability and pulmonary capillary pressure. This could also mean lymphatic insufficiency, which causes decreased oncotic pressure, increased negative interstitial pressure. It could be from unknown causes. But basically what we're talking about in this whole non-cardiogenic is that we're going to get fluid that builds up in the interstitium, or in the interstitium and the alveoli, and that fluid's going to build up in that area around the heart and cause pulmonary edema. So regardless of what's going on as far as increased capillary permeability or capillary pressure or lymphatic insufficiency, we're talking about non-cardiogenic pulmonary edema. We're getting that fluid that builds up in the interstitium or the interstitium and the alveoli in the lungs. When we're talking about pulmonary edema, remember we're talking about the fluid building up around the lungs, and it can be cardiogenic or non-cardiogenic. And depending on which type you have will determine what type of clinical manifestations you have. But regardless of the type, the first thing you might see is that cough, that shortness of breath, the tachypnea or the increase in respirations, and fatigue. Remember, the lungs are struggling to get the air exchange like they would need to support the body. So whenever there's fluid building up around the lungs, whether it's because of the heart failure or because of some type of capillary permeability issue, the fluid's building up in the alveoli. And when that alveoli, which should be a normal air space, starts to fill up with fluid, the patient's going to experience severe dyspnea or difficulty breathing, tachypnea, increased respiratory rate because the body's not getting adequate exchange. It's going to try to breathe faster to get more oxygen into the bloodstream. You might see a frothy sputum production. Remember, normally the alveoli would have air. When they start filling up with fluid, the body starts trying to get rid of that fluid by coughing it up. Because we're not getting the gas exchange, we're going to have decreased saturations, so we're going to see our O2 sat going down. And think back to health assessment. What did we say was a good assessment that you would hear if there was fluid building up in the lungs? So that goes back to those crackles and those wheezes and those bronchi. So you want to really listen to those lungs to determine if you can hear the fluid building up. If the body's not getting the oxygen it needs, we're going to see that central cyanosis, or that bluish tint around the lips or of the mucous membranes, circumoral pallor, circum meaning around, oral meaning the mouth, pallor meaning pale. So you're going to see pale around the mouth. You'll start seeing the lips turning that blue, that's from that central cyanosis. We also said that any type of hypoxemia will cause mental changes. So we might see our patient that has agitation. They may be confused. So we're seeing changes in level of consciousness. If we're linking our pulmonary edema directly to cardiac origin, we're going to see tachycardia with hypotension or low blood pressure, and that cool diaphoretic skin. Because the heart's not pumping effectively, it's going to pump faster. That's that tachycardia. But it's not pumping effectively, so our blood pressure is actually pretty low. It's not squeezing the blood out like it needs to, so the pressures are going to be low. When the body senses the pressures are too low, it's going to cause systemic vasoconstriction because it wants to keep the blood to the central organs versus the extremities. So your skin may feel cool and kind of diaphoretic because the blood is being kept centrally to keep the heart and the brain and the major organs hopefully perfused. Also, you're going to see jugular venous distension. Remember when you did your assessments in health assessment, we looked at the jugular veins and we were looking for distension. Well, the reason we were looking for that is because if we have jugular venous distension, oftentimes that's a sign of the heart not pumping the blood effectively. The blood is starting to build up. That's why it builds up back into the lungs. But the veins have got to be distended to show that there's a buildup happening. If we're talking about non-cardiogenic pulmonary edema, we might have tachycardia with hypertension. Because at this point, it's not related to the heart not pumping effectively. But the body still notices that it's not getting rid of the CO2 or not getting the oxygen that it needs. So we're still going to have the tachycardia because the body's going to try to pump more blood out to the body organs. The body knows that the blood's not as oxygenated as it needs to, so it's going to send twice as much. But when the heart starts to pump effectively, which is in the non-cardiogenic, if it starts to pump faster, it's going to increase our blood pressure. The body knows that it needs to get more blood to those organs faster because the oxygen that's getting there, the quality of the oxygen, is less than desirable. So that's going to be, we're going to see the tachycardia with the hypertension. And that, in this case, you're going to see those bounding pulses and that dry skin. So you can see there's a difference between what the patient looks like with cardiogenic and non-cardiogenic. We still have some common ones, the cough, the fatigue, the crackles, anything that would deal with the fluid in the lungs, but the origin is going to be different when it comes to the different symptoms. As far as with cardiogenic, we're talking about tachycardia with low blood pressure, but with non-cardiogenic, we're talking tachycardia with high blood pressure. With cardiogenic, we're talking that cool and diaphoretic skin because of that lack of blood pressure. But with non-cardiogenic, we've got the bounding pulses and the dry skin because of the increase in blood pressure. So you have to pay attention to what type of clinical manifestations you see, and that'll also help you determine what's our cause of our pulmonary edema, whether it's cardiogenic or non-cardiogenic. We're going to diagnose pulmonary edema by doing pulmonary artery catheter wedge pressure and pulmonary artery occlusion pressure, which are two types of hemodynamic monitoring that we'll talk more about when you get to med-surg 2. But we're actually looking at the pressure of the blood going to the lungs. In addition, we're going to look at the chest x-ray, and oftentimes on a chest x-ray, especially if it's cardiogenic, you'll see an enlarged heart, because if you remember, the heart is a muscle, and if the muscle's not pumping effectively, it's going to pump faster, so we get that tachycardia. And with that tachycardia, the heart's working harder, and just like any muscle that works harder, it can become enlarged. So we're going to be watching our chest x-ray for things like the enlarged heart. Also, if you looked up a couple slides earlier, I showed you two x-rays that showed you what pulmonary edema would look like over the lungs, where you had the fluid buildup over the lungs, and it showed you what was after treatment. You can see the difference in the colors over the lungs. That would show that there's fluid over the lungs in the first picture and that the fluid is gone in the second picture. So you can see infiltrates, you can see fluid, you can see enlarged heart. And then we're going to be sure we get a good patient history, because we said there's so many different types of cardiogenic and non-cardiogenic pulmonary edema. We've got to know a little bit about the patient history. For example, if we know that they were a known drug addict, we might really start considering this to be a heroin-induced pulmonary edema. If we know they have a history of heart failure, maybe this is a cardiogenic. So we're going to look at all the different things, including the patient history, to diagnose pulmonary edema. Medical management for pulmonary edema oftentimes will focus around the cause of the pulmonary edema, whether it's cardiogenic or non-cardiogenic. But when we're talking about pulmonary edema in general, whether it is cardiogenic or non-cardiogenic, there's some common things that we do for both. The first thing is we're going to provide supplemental oxygen, and we're going to titrate it to increase our O2 sat, because we want to make sure the body's getting adequate oxygenation. If we put the oxygen on, and we've noticed the oxygen saturation's not going up, or the patient's not responding to it, then we might have to intubate and use mechanical ventilation. So we're talking about putting an intubation tube down their throat, in their airway, and hooking them up to a ventilator. We know that that also runs the risk of increasing our patient's risk for pneumonia. By opening the airway, we could possibly introduce bacteria into the lungs. So recently you might have seen patients with a non-invasive positive pressure ventilation system. And that simply means non-invasive, means we're not putting that intubation tube down in the airway, but we're still giving them positive pressure ventilation. So the machine's still forcing air into them, but we're doing it without actually having to putting an intubation tube down. And the concept behind giving positive pressure ventilation is that if we can increase the air pressure that goes into the lungs, it can actually help force gas exchange. So it's going to be hooked to an oxygen source, but we're going to actually be doing a positive pressure ventilation. And we said that with cardiogenic pulmonary edema and non-cardiogenic, one has hypotension, one has hypertension. So we also want to make sure that we're giving good blood pressure support to make sure that we're keeping our blood pressure levels within normal range. In the previous slide, we talked about general medical management for pulmonary edema. If we break it down further and we talk about specifically cardiogenic pulmonary edema, we're going to be focusing on factors that are related directly back to the heart's inability to pump effectively. So we're going to make sure we do airway management to make sure we're keeping that oxygenation status adequate. And then vasodilators, diuretics, inotropes, we're really focusing on not only cardiac output, meaning afterload, but we're also going to be focusing on preload. And then we're going to be giving morphine. And I'm not going to go into the medications because that's going to go back into your pharmacology course. But we're really focusing on the fact that the heart itself is not pumping effectively. So we're going to give different medications related to that. Just some general things to keep in mind. If a patient's already hypovolemic, we don't want to give our diuretics. If our patient's already got severe hypotension, we want to be careful with the morphine. We don't want to cause even more hypotension. So these are just some options that we would use, but we want to be real careful to look at the patient in general and their cardiac status. If we're talking about non-cardiogenic pulmonary edema, that's pretty much supportive care, and we've got, which we figured in the previous slide, was oxygenation, making sure that the O2 sat stays up, keeping them hemodynamically stable until we can figure out what the underlying cause was. For example, if it was related to heroin, we'd have to keep them managed until we got the heroin out of their system. If it was directly linked to giving too many IV fluids, this happens a lot when you've got patients who are dehydrated, or they become hypovolemic, and then we give aggressive fluid replacement with 3% saline. Now remember, normal saline is 0.09, so 3% is 3 times as much. And we know where salt goes, water goes, so 3% is a lot, which will have the patient hold a lot of fluid quickly. So if we gave, say, 3% saline solution to correct hypovolemia, we have to be careful that we don't get into hypervolemia, which could cause us to go into pulmonary edema. So we're going to do supportive care and treat the underlying cause, whatever it may be, which is why we're going to get that really detailed history from our patients. We can determine what is our underlying cause if it's not cardiogenic. So looking back at the management we just talked about, let's talk about what the nurse's management is going to be. We're going to watch for those signs and symptoms of hypoxia and progressive respiratory failure. And we talked about shortness of breath, changes in mental status like restlessness, tachypnea, increased breathing so the body can get more air in so it can get more oxygen in. You're going to see the patient using accessory muscles and have an increased respiratory effort. The lungs, in essence, are being squeezed with that fluid and filling up with fluid, so it's going to be very difficult for the patient to breathe. We're going to see oxygen saturations that are going down. We're going to see cyanosis. We said earlier that we're going to make sure we auscultate all of the lung fields. We're going to be looking for crackles. Remember those crackles and those rhonchi? Those are a good indicator of fluid building up in the lungs. We definitely want to talk to our patient if they're able to speak to us and get a patient history. If they can't speak to us, we want to look through their medical records. We want to speak to family. We want to see what is the background to help us determine what's going on with this patient. So just based on what we just talked about, some of our nursing diagnoses for our patient with pulmonary edema would be impaired gas exchange. That's the biggie here. We know that the lungs are filling up with fluid, and those alveoli can't have fluid. They're supposed to be air spaces. If they're not air spaces, the gas isn't exchanging. So not only are we not getting the oxygen that we need in, sometimes we're not getting the CO2 out like we need to. So there's that impaired gas exchange. And then because of all the extra effort the patient's using to breathe, a very common diagnosis is fatigue. But remember, we expect them to be tired. We expect them to be somewhat weak. But when we see that our patient's getting to where they get that somnolent or that inability to kind of wake up, and you're trying to wake up and they're just so tired, we know that the respiratory efforts are going to start decreasing because the body's just getting tired. And we know that when they get to that point, they're very close to having respiratory arrest. So we've got to notify somebody quickly that that somnolence is not a normal finding. So what are we going to do? We want to position our patient to promote lung expansion and prevent aspiration. Oftentimes that means sitting them up. That allows for that lung expansion. Keep a close eye on those oxygen saturations. This might not be that once a shift O2 sat. This is going to be a continuous one. And when those levels start to drop, the monitor alarms are going to go off. We're going to keep an eye on our ABGs. Even though the doctors are going to look at them and our respiratory therapists are going to look at them, nurses are going to keep an eye on those because we're the ones that are with the patient all the time. It allows us to determine their progress. Are they getting better? So it's important that you understand how to read an ABG. Okay? Notify the healthcare provider if there's increased oxygen requirements. If we've got oxygen on them and they're not responding, or we notice that with oxygen their levels are starting to go down, remember we might have to do intubation or non-invasive positive pressure. Okay? Monitor that patient's energy level. We expect them, again, to be tired, but we don't expect them to be so tired they can't stay awake. If they get to that point, again, we're headed for respiratory arrest. Not a good thing. And then sometimes the patients will have, because of the coughing and because of the increased fluid volume, if it's because of hypervolemia, as needed, make sure that we help to clear any kind of secretions. We've already got ineffective gas exchange going on. We don't need to have impaired airway clearance on top of that. So if there are any kind of secretions, we might have to suction if the patient can't effectively cough them up. So what are we looking for? We're looking for adequate oxygenation. We're looking for a normal respiratory rate and depth. Hopefully we're not using those accessory muscles anymore. Relaxed respiration, meaning they're not so tense, they're not struggling to breathe. The absence of dyspnea or the absence of difficulty breathing, and we hope that our ABGs will be within that patient's normal parameters. So let's move on to acute respiratory failure. We mentioned respiratory failure, we talked about pulmonary edema and if it got out of hand. Now there's two types of acute respiratory failure: acute respiratory distress syndrome, or ARDS, and acute lung injury. And basically what ARDS is when you have hypoxemic respiratory failure. So we've gotten to where we've got no oxygen getting into the bloodstream, our oxygen saturation levels are dropping, and we go into respiratory failure. And what's happening with ARDS is that we get so hypoxemic that the alveolar capillary area becomes inflamed and becomes damaged. And we categorize these two, acute respiratory distress syndrome and acute lung injury, together because they're essentially the same thing. Whereas ARDS is a hypoxemic respiratory failure, ALI is a less severe form. And I don't expect you to understand exactly how it's categorized, but what we're looking at is the PaO2 to the FiO2 ratio. And what that ratio reflects is the degree of hypoxemia. So the lower the number, the worse the disease. And you're going to have to get an ABG to determine this PaO2-FiO2 ratio. So when we have a higher number, we're talking about a less severe form of ARDS. The lower the number gets, the lower the ratio, the more likely you are to get actual ARDS. So we categorize them the same. It's just the extent of kind of like mild blood pressure, mild hypertension versus severe hypertension. We've got a milder form of respiratory distress. But don't discount them. They're still both forms of acute respiratory failure. When it comes to determining the epidemiology of ARDS versus ALI, it's kind of been difficult to determine the incidence. Because they're often categorized in the same area, it's hard to break down how many people actually have ALI versus actually have ARDS. Currently, we think that there's about 86 per 100,000 people per year for ALI and 64 per 100,000 per year for ARDS. But again, that's hard to determine because a lot of times they're categorized together. We do know that people that are over 75 years old have a higher incidence, and that when we're talking about full-blown ARDS, we have a mortality rate of 30 to 50%. But of course, that rate's going to vary depending on the severity of the disease. Usually when we have respiratory failure, our patients are going to die from a multiple organ failure because remember, all of the cells in the body are not getting oxygen. So our patients will usually die because of an organ failure system versus actually dying from respiratory failure. The one thing that is easy to determine is the etiology of acute respiratory failure. And that's basically the consequence of some type of a lung injury. It can either be a direct lung injury or indirect. And what's happening is we're having diffuse alveolar damage. And we know that we have to have those alveoli to get adequate gas exchange. So when those alveoli become damaged, we're not getting the gas exchange, we start going into respiratory failure. So what do you think the clinical manifestations of ARDS and ALI are? Well, we know that they're both forms of respiratory failure, so we're going to start seeing those clinical manifestations of respiratory failure. So our early on symptoms, things like hyperventilation. We might start seeing some respiratory alkalosis going on. Think back to your ABGs. As the hypoxemia continues and continues to get worse, we might start seeing that difficulty breathing, the shortness of breath. We might start seeing tachypnea and use of accessory muscles. We might start seeing the cyanosis and the mottled skin. And these aren't going to get better with oxygenation. And why? Because we said the alveoli are damaged. It doesn't matter how much oxygen we put in there, if they don't have the capacity to have gas exchange, then the oxygen is only going to go in and come right back out. It's not going to actually be perfused. We might start seeing substernal retractions. When we're listening, what are we going to hear? We're probably going to hear crackles in our lung bases. We might hear rhonchi and wheezes, depending on how much fluid is actually flowing into the alveoli. We might start seeing that pink frothy sputum that we said we saw with pulmonary edema, because again, we're getting that fluid in the lungs. As the hypoxemia continues to get worse, we notice that we give oxygen, and of course, RO2 sats aren't going up. At this point, our patient's probably going to need to be intubated and given mechanical ventilation. Based on our symptoms, we start looking at our medical management. And for the most part, it's supportive. We're going to focus on treating the underlying cause. We already talked about mechanical ventilation. We want to avoid complications. And in some cases, you might see what they call novel medical therapies. And what that really means is there's new alternative therapies that are being used to try to treat ALI and ARDS. But at this point, none have really been shown to show extensive benefits. But it may be therapies like inhaled vasodilators. There may be, you may see a doctor give surfactant administration, maybe liquid ventilation, anti-inflammatories. These are just alternative therapies that are being tried, but at this point they're still considered novel because they don't have significant research to show that they're effective. When it comes to nursing management, we always have that continuous assessment, and we're looking at airway and oxygenation status. We want to look at our subjective and our objective findings. What are we seeing versus what the patient says. So our objective findings might be respiratory rate, oxygen saturation, our ABG results. Those are what we actually get results from. And then remember our subjective, if you forgot subjective versus objective, you want to go back to health assessment. But subjective would be, what did the patient say? Or what is the patient complaining of? How do they feel? Some of our nursing diagnoses that would go along with ALI and ARDS, well, impaired gas exchange would be right there at the top. Remember, our alveoli are not functioning properly because of damage, so we're not getting the gas exchange, which is ultimately the cause of our respiratory failure. Ineffective tissue perfusion. If we're not getting the necessary oxygen to the bloodstream, we can't get effective tissue perfusion. Ineffective coping. Oftentimes, ARDS and ALI comes on suddenly, and sometimes patients are, have a lot of anxiety related to it. You can imagine, if this came on and you're facing respiratory failure where there can be ineffective coping. Nutrition, less than required. We said that sometimes our patients have to be intubated when they get to this phase. If the patient's intubated, then they're going to rely solely on the nutrients that are given through the IV, or if the odds, they may have a G-tube where we can actually give it through the stomach, but they're going to be relying on alternative sources of nutrition because they can't take in nutrients because they've got a tube down. They're at risk for infection. We've got relatedness to the disease process. We've got all that fluid building up in the lungs. It can also be because of all the invasive lines that we've got going in, all the different monitors that we've got on them. This may be a direct result of pulmonary edema, so we're monitoring pulmonary wedge pressure. That's an invasive line. It can also be related to the fact that they're intubated. We're opening the airway. We could potentially be exposing bacteria into the lungs. And then they've got risk for impaired skin integrity. Now, why would you think they would be at risk for impaired skin integrity? Well, we said that most of the time our patients either have a difficult time breathing. If they're already having difficult time breathing, they're not going to be getting up and moving around very much in the bed. But on the other note, if they're intubated, they're not going to be moving. So we got to make sure that our patients who have limited mobility, that we're doing that turning every 2 hours and repositioning, because we don't want to also expose them to impaired skin integrity. Some of our interventions related to ARDS and ALI, if the patient's still able to breathe on their own and be successful in actually getting their own air in without having the use of a mechanical ventilator, we want to encourage them to do deep breathing and coughing exercises. That would include the use of an incentive spirometer. And you can see in the picture, this is an incentive spirometer. Now, this is not a blowing out technique. This is where the patient puts their mouth around the tube and takes deep breaths and breathes in. And you'll see the little device move up and down as they breathe in. And they set goals, because the deeper the breath, the more likely they are to help with the fluid buildup in their lungs. If the patient does have to be intubated, we want to make sure that we have a successful intubation, meaning that we have the tube in the right location, that it hasn't gone down the right or the left bronchial stem. We also, if we have to use an ambu bag, we want to demonstrate skill with suctioning and the use of the air mask bag unit. And now you know the ambu bag is not going to be for long term, but if a patient goes into respiratory arrest or severe respiratory distress, until we can get our supplies together and get the intubation tube down, it may be that we have to use that ambu bag. So it's really important that the nurse understands how to do appropriate suctioning and how to use that ambu bag to make sure that we're getting the adequate amount of airflow that we need to into the patient's lungs. So our outcomes related to ARDS and ALI, well, we hopefully will have a stable oxygen status. And hopefully, because we're so close to actual respiratory failure, we want to prevent or resolve that respiratory failure. Okay? Because we know that long-term respiratory failure is going to lead to cardiac failure, and eventually your patient's going to expire. So we want to make sure that we prevent it if possible, and if it comes on, we want to resolve as quickly as possible. How do we know we've met our outcomes? Well, our vital signs and our oxygen saturation are within normal limits on room air. That's our ultimate goal. It may take a while to get there, but that's our ultimate goal. We said that the crackles and the rhonchi in the lungs indicated that there was a fluid buildup in those lungs. So an outcome would be those lungs are sounding clear. And just overall, the patient's going to say, I don't have any difficulty breathing anymore. Or I don't think I'm struggling to get air. So that patient denies that shortness of breath or air hunger. If a patient's been hospitalized for respiratory failure or ARD, we have to understand that oftentimes the patient will have been in the hospital for weeks to months, and oftentimes they've been receiving mechanical ventilation. So in the event that the patient gets well enough to go home, there's some things that we have to talk about with regards to discharge priorities, and we're talking about quality of life issues. It is important to understand that quality of life is going to mean different things to different patients, and it's important to understand how your patient views quality of life as we're discussing their recovery from ARDS. When the patient's discharged, whether they go home or they have to go to a rehabilitation facility, the quality of life is going to be different than before they had ARDS. There could be exercise limitations. Well, there will be exercise limitations. Just to what extent will depend on the patient individually. There's going to be physical and psychological sequelae or afterthought. There's going to be things that patients notice that are different physically. They're going to have a different psychological or mental state. There's a decreased physical quality of life. And again, quality of life is going to be variant, but they're not going to be in the same physical condition as they were pre-respiratory failure. In addition, we all know that for those that do have health insurance, it doesn't cover everything. And even for those of us that do have health insurance, being in that hospital for that long of a period of time on such high level acuity can mean that you may come out with large medical bills. Depending on your level of rehabilitation, the medical bills may still continue to mount up after you are discharged within the rehab phase. And many of these things that we just talked about can be very overwhelming to your patient. You know, not only did they not expect to have respiratory failure, they come out, they're completely changed. They have all these limitations. They've got all these bills. So we've got to really look at our patient as a whole when they're being discharged. They can become depressed. They can have anxiety related to their physical limitations, related to their financial status, related to fear of the unknown. Is it going to happen again? They may have lost some of their cognitive ability. We said that the body didn't get the oxygen it needs, and we know that affects your brain functioning, so they may be coming out with different cognitive abilities. They might have recollections of being in the ICU, and those can be traumatic. They may remember going into respiratory failure and having to be intubated before they were given any kind of medications. That can cause stress. They might actually have delusional memories. We know that, again, it affects your cognitive or your mental thinking, so they may come out with delusions. I remember that there were, people dancing all over the room and things that we have to make sure we kind of help clarify with them. But this ARDS and respiratory failure are definitely precipitating factors for post-traumatic stress syndrome, because patients just are not ready for respiratory failure. This isn't something that comes on gradually in most cases. It just kind of happens. So we want to make sure that we're not only supporting them physiological, meaning, with their body functions, we want to make sure we also consider that psychological state. Okay, well, that's going to conclude our respiratory disorders lecture. So we're going to move now into endotracheal intubation. You may not be a part of this frequently when you work as a nurse. It depends on where you work. If you're going to be working in the recovery room or the operating room, you're going to see it quite frequently. If you're working in an ICU, you're going to see it quite frequently. On the side note, hopefully if you're working on a regular med-surg floor, you're not going to see this intubation process done very often. But it's important as a nurse to understand what your priorities are during an endotracheal intubation. If you're around when there is an intubation, you also are going to be asked to assist. Okay? If the patient is alert and can understand you before they actually intubate, try to explain the process to the patient. Let them understand what you're going to be doing. Oftentimes they're already in respiratory distress. They're already full of anxiety. So do your best. They may not understand everything you're saying, but you just have to assume that they do. Explain it to them. If there's a family nearby or any loved ones that are nearby, make sure you're explaining to the family what's going on. Again, they can be very anxious too. Their family member is in respiratory distress and they don't know what's going on. So you want to explain it to the patient and the family. You want to confirm that the equipment is working properly, which means you want to understand how a ventilator works if there's no respiratory therapist around. Make sure that your oxygen is working correctly. Make sure you've got the supplies you need. We're going to provide 100% oxygen with a non-rebreather mask if the patient's able to breathe on their own. If not, we're going to be using an ambu bag with oxygen attached to it. Okay? This is not a nasal cannula. This is not just a simple face mask. We're going to be using a non-rebreather, or we're going to be using a specialized ambu bag that's going to give that patient 100% oxygen. Okay? And then if we notice that there's secretions in the throat or in the upper respiratory tract area, we're going to provide suction as necessary. When it's actually time to intubate, we're going to be watching that patient's oxygen saturation, the heart rate, and the blood pressure. Again, your level of involvement will be dependent on who's available. Sometimes if respiratory therapy is available, you just kind of sit back and watch, but you still help watch that oxygen saturation, the heart rate, and the blood pressure. If you're assisting a physician doing it, you may be asked to document the size and the location of the endotracheal tube. You're going to document any medications that were administered. Sometimes they're going to be able to sedate the patient in advance if they know that they've got some time to get the patient relaxed. Sometimes if it's an emergency, there's no medication that's actually done. And then when it's all finished, you're going to document how the patient tolerated the procedure. Although you might not be responsible for actually putting in the endotracheal tube, you're going to be responsible for assessing. And I do want to point out that you hear a lot about endotracheal intubation, which is where we go in through the mouth and go into the trachea. There's also a possibility of doing a nasotracheal intubation. And if you think back to when we were talking about fractures and maybe mandible fractures, if we've got any reason why the tube cannot go through the mouth, we can still do intubation through the nose. And you can see in the picture, it still goes down into the trachea. So it's the same concept, just going in through a different airway. Now, when we're doing an ongoing nursing care, we want to do ongoing assessment. So we want to make sure that we're looking for things like tube position. And once the tube is confirmed by x-ray that it's in the right place, oftentimes it's marked either with a piece of tape or with a permanent marker, so that you can look at the tube to determine if it's been pulled out or pushed in. So we're going to be looking at the tube placement. We're going to be watching for a tracheoesophageal fistula, which would mean that we'd get constant pressure from that tube being exerted on the tissues. And with that constant pressure, it can cause the inflammatory process to kick in. It can cause irritation. And that can actually lead to a breakdown of the trachea. So a tracheoesophageal fistula, you remember fistula kind of means an opening. So if we've got this constant pressure that can cause a breakdown of the trachea, you can actually get an opening that would open up between the trachea and the esophagus. So we have to really be careful that we're monitoring to see if there's a possibility of that fistula, that pressure, that opening. We don't want to have an opening between the two. We're going to keep an eye on the patient's mouth, lips, If it's going in through the nose, we want to keep an eye on the nose. Okay, we want to keep them dry. I don't mean to the point where they are cracking dry, but we don't want them to get saturated with fluid or mucus, because that we know that any time skin gets wet, it opens the medium for breakdown. We want to look for pressure necrosis. Just like if you're laying in the bed and you get a pressure ulcer, if we've got pressure with that tube being placed on the nose, maybe the nares, on the mouth, anywhere that tube is laying against the patient can cause damage and breakdown and ultimately necrosis of the tissue around it. So we're going to be watching where the tube's inserted. Also, think about the fact that this patient's got a tube in, and while it's opening up the airway, say from the mouth down or from the nose down, if we've got an airway in that's going in the nose, and you can look in this picture, you see the airway going in the nose and down into the trachea. What is it doing? It's also blocking the sinuses. So if you've got one with a nasotracheal intubation tube in, we want to watch for sinusitis or inflammation of the sinuses, because we're blocking the ability of the sinuses to drain. They would be normally going down the back, and now we've got this blockage going on. So we want to watch for sinusitis. Okay. With regards to the tube placement, one thing what's really important, whether it's an endotracheal or nasotracheal, is to make sure that we watch for obstruction. How do you think you would know if there's obstruction of a tube? Well, it would be the same thing as if we had obstruction of an airway, whether the patient was choking on something or whether we had some kind of a tumor. An obstruction is going to indicate that there's no air getting down. Even though they're on a ventilator, there's no air getting down. So for us, it may be that we hear the alarms going off on the monitor. Then we also have to look at the non-monitor things, like our oxygen saturation. It could be that we start seeing cyanosis. So make sure you're looking for systemic effects as well. We can't always rely on the monitors. Okay, because we talked about the intubation and we talked about being mechanically ventilated or put on a ventilator, let's briefly go over a little bit about mechanical ventilation, just to get kind of an understanding of what we're actually talking about when we're talking about the ventilators. Some implications that would lead us to put a patient on mechanical ventilation, meaning there's a machine breathing for the patient or assisting with breathing. Things like hypoxemia, okay, which was the low oxygen, or the hypercarbia, which was too much CO2 in the blood. All types of mechanical ventilation include some type of a ventilator circuit. That simply means that the ventilator circuit is connected to the patient. Usually it has a single plastic tube that fits directly into the endotracheal tube or the tracheostomy or the nasotracheal, but it's actually feeding directly into the tube where the patient's been intubated or has a trach. Then the circuit divides into an inspiratory circuit and an expiratory circuit, and you can kind of follow along with the picture at the bottom. Okay. And the expiratory circuit connects directly to the ventilator, and so does the inspiratory circuit, but they do divide, so you can see that. And you can see the ventilator or the monitor is actually going to monitor the rates, it's going to monitor pressures, and it's going to monitor volumes. You also note on that picture that you have at the bottom, you also see a humidifier. Remember that when a patient is intubated, whether you're using a tracheostomy opening, or a nasotracheal, or an endotracheal, whenever we're using a tube, we're bypassing the body's ability to humidify the air. So on the inspiratory tubing, we actually have a humidifier, okay, because we want to make sure that the air that they're getting is humidified. And again, the monitor is going to monitor rates and different pressures and different volumes. For the most part, as a nurse, you are not going to be setting these pressures and these volumes. That's going to be done by respiratory therapy. The one thing that's important for nursing to note is what volumes and what pressures, what is your ventilator set to, so that you can kind of keep an eye on it. So if I know, for example, that this was the parameters that the respiratory therapist set on my ventilator, when I go assess my patient throughout the shift or even the next day, my first thought process with the ventilator is to make sure my ventilator settings are the same. If they've changed, I want to go back and look in the respiratory therapy notes to make sure that they were changed by respiratory therapy. Sometimes, although it doesn't happen because they have pretty good locks on it, but sometimes people can come in there and actually start changing volumes and pressures, and on these ventilators, and they shouldn't be. So you want to make sure that you know how to at least read the pressures to know that you can make sure that the rates haven't been changed. And there are a couple different modes of ventilation. And we talked a little bit about this in the upper and lower respiratory lectures. And I told you we would talk about them a little bit more in detail when we came to the complex. So here's the different types of modes of ventilation that you might commonly see. The first is the volume targeted mode. And just like the name indicates, this is also called volume controlled. Basically, there's a selected set tidal volume that's delivered during the inspiratory phase of ventilation. So basically, the machine's going to give a certain amount of volume during the inspiration cycle. When that volume is reached, and remember the machine's measuring the volume, when that volume is reached, the expiration cycle will begin, or the exhale. Okay. So the inspiratory pressure will vary depending on the compliance and resistance of the lungs. So the machine's going to measure the resistance, is going to measure the pressure, and when that pressure is met, we're going to go into the expiration phase. Okay. And there are various types of volume targeted modes, and we're going to talk about those on the next slide. But the second type of basic mode of ventilation is a pressure targeted mode, also called pressure controlled. These also have a set inspiratory pressure. And with this, during the inspiration phase of the ventilatory cycle, an inspiratory breath is delivered until the pressure setting is reached. Again, when that limit is reached, inspiration will stop, expiration will begin. Again, the tidal volume that's going to be delivered is going to depend on the lungs' resistance and compliance. And there are a couple different kinds of this one, and we'll talk about those in two slides from now. But just know there's a couple different kinds. I really don't expect you to remember the different modes of ventilation, but there's always questions about what's the difference between volume targeted and pressure targeted. Just listen to the lecture part and just kind of listen to it and understand what's going on. But again, I don't expect you to be able to remember specifically, as most of this is done by your respiratory therapist. The third kind of ventilation is a continuous positive airway pressure. By looking at that, you can recognize that as what we call CPAP. Now, this is not pressure targeted or volume targeted. Actually, with this one, the patient's going to breathe at their own rate and their own tidal volume. And what's going to happen is the ventilator is going to put a continuous positive pressure in the airway. And that continuous positive pressure is there to open up or to prevent those alveoli from collapsing. We talked about using this with your sleep apnea patients, but in this particular case, when it comes to mechanical ventilation, oftentimes as you're trying to wean a patient off of the volume targeted or the pressure targeted mode, then you're going to put them on a CPAP. And what it's going to do is it's going to identify the patient's ability to ventilate without assistance. And you do that before you remove the whole intubation tube, because if they can't maintain themselves on their own with the CPAP, then we might turn them back onto the volume targeted or the pressure targeted, where the machine's doing the breathing for them. But it's kind of a step down if they can maintain their own, because again, CPAP is letting them breathe on their own. It's just giving a little bit extra pressure while the patient breathes in. If they can maintain that on their own, then they might be able to be extubated and maybe just put on a CPAP with a non-invasive. So this is kind of seeing how the patients can adjust and breathe on their own. And the last basic mode I want to mention is positive expiratory pressure, or you may hear this called PEEP. And this is a ventilator setting. It's not a type of ventilator, but it's a ventilator setting that you'll have. And what it's going to do is give continuous pressure above the atmospheric level on the airway. And that's done during both inspiration and expiration. So it's causing pressure. And what it's trying to do is help open the alveoli during inspiration and help that alveoli not to collapse during expiration. In the previous slide, I mentioned volume-targeted modes of ventilation and pressure-targeted modes of ventilation. And I said there were different kinds underneath it. Now remember, your volume-targeted, also called volume-controlled, okay, they have a selected set tidal volume that's given during the inspiratory phase of the ventilation cycle. The different kinds would be something like continuous mandatory ventilation. And what continuous mandatory ventilation is the ventilator is set to give a certain number of breaths per minute. So for example, if it's set to give 12 breaths per minute, it's going to mechanically force the patient to breathe 12 times during the minute. Now, if the patient's able to breathe on their own, they can actually breathe in between the breaths. So they can breathe at their own rate in between these mandatory breaths, but the patient-initiated breaths are not calculated by the ventilator. The ventilator doesn't care if you breathe 25 times on your own. It's going to make sure that you breathe that 12 times that it is set. Okay, so basically the ventilator ignores how many times you breathe, but you can still breathe on your own. Now, this is relatively uncomfortable for the patients because can you imagine something forcing you to breathe when you're not ready to breathe? Especially if you can breathe on your own, all of a sudden something's forcing air down your throat or down your trachea and making you breathe. Usually this continuous mandatory ventilation, you can see how that can be very distressing for a patient. If a patient has to be on this, we always try to sedate them or chemically paralyze them. So basically they have no spontaneous effect. They're not trying to breathe on their own, that the ventilator is doing all of it for them. Okay. The second kind is the assist control ventilation. Kind of a step down from your continuous in the fact that the patient actually initiates the breath, but the ventilator is going to control the breath and end the breath. With this, you have to think to yourself, what if the patient doesn't breathe enough on their own? If the healthcare provider has ordered that a patient's supposed to breathe, say, 16 breaths per minute, and they're only breathing 12, the ventilator will actually initiate the other 4 to make sure they stay on track. But whereas the continuous mandatory ventilation, the ventilator ignored the breath the patient took, the assisted control ventilation is actually going to monitor the fact that the patient is breathing. So if the patient breathes the total amount of 16, it's not going to give them a breath. It's just going to support their breath when they take it. But if they're not meeting their breath like they need to, it's going to actually initiate breath for them. But it doesn't matter how the breath is initiated, whether it's the ventilator that initiates it or whether it's the patient, the preset volume is delivered each time the breath is initiated. So the patient has, in essence, it's going to make sure you're breathing enough. If not, it's going to initiate a breath for you. And when you initiate a breath, it's going to make sure you get enough volume. Because remember, that volume is what we need to make sure those alveoli don't collapse. And the last kind of volume targeted is synchronized intermittent mandatory ventilation. And this is probably the one you're going to see the most. With this one, both the patient and the ventilator can initiate breath, like it did with the assisted control. But the machine's got a preset rate, and those preset breaths are going to receive a full set of tidal volume. The difference between this one and the assist is that with the assist, if the machine sensed that you were breathing, or the patient was breathing, it was going to give you the full tidal volume with your initiated breath. With the synchronized intermittent mandatory ventilation, the machine's going to recognize your spontaneous breath, but it's not going to assist you. Okay, the patient's going to be determining the tidal volume. So just kind of a quick review, these different volume targeted modes are pretty much the same type of concept except for the continuous. The breaths are initiated, controlled, and terminated by the ventilator. The ventilator ignores the patient altogether. So we're going to sedate our patient. With assisted, both the patient and the ventilator can initiate the breath, but if the ventilator tracks that the patient's breathing, it's going to assist them to have a full tidal volume. So it's going to say, oh, you're taking a breath? Here's the rest of the breath. Make sure you get the full volume. In addition, it's going to deliver preset breaths. Okay, so it's going to count, and where needed, it's going to give its own breathing, but it's also going to give the full support to the patient that's breathing on their own. With the synchronized intermittent mandatory, again, both the patient and the ventilator can initiate the breaths. But the machine's got a preset number of breaths it's going to give regardless. Okay, so if the machine's going to give you 12 per minute regardless, it doesn't matter that you breathe 12 more times. That just means your respiratory rate's going to be 24. Okay, with that, with the patient actually breathes, the machine's going to count it, but it's not going to give support with the patient's breath. So it's not going to actually kick in. It's going to count it, but it's not going to give support. But it doesn't matter how many times you breathe, the machine's going to still give its set number. Okay? So you can kind of see how those work. Now the pressure-targeted modes of ventilation, again, we call those pressure-controlled. They have a set inspiratory pressure. Whereas the first one was volume, the pressure is a set inspiratory pressure, not volume. And they have pretty similar concepts concepts to your volume targeted. If we're talking about pressure control ventilation, it's very similar to your assist control ventilation, except that instead of setting the volume being delivered, an inspiratory pressure is targeted. Okay, so you set the rate and you set the pressure. Now the volume is going to vary because we said that lungs, depending on their ability of compliance, how much they stretch or they don't stretch, will determine pressure. So it may take, for example, if your lungs are very elastic, it may take more pressure, more volume to get to a certain pressure. Whereas if the lungs are damaged and they don't have good expansion, it may take less volume to get to a certain pressure. So with the pressure targeted, we're looking more at pressure versus volume. So pressure controlled is very similar to your assist control, except for instead of setting the volume, you're setting the pressure. So when the patient breathes, the ventilator is going to assist, just like it did with assist control. But rather than giving a specific volume of air, it's actually going to give enough air till it reaches a certain pressure, and then it's going to stop. And the last kind is pressure support ventilation. And this is also an assisted type of ventilation. With this one, the patient's got to have a reliable respiratory effort. They have to be able to kind of initiate the breath on their own. But what the ventilator is going to do here is when the patient initiates the breath, the ventilator is going to support them. And how much support is given will depend on the pressure setting on the ventilator. So the higher the set pressure support, the more the ventilator is going to do the work for the patient, because the ventilator is going to be giving enough air to cause a certain set of pressure. And again, the patient has to be breathing on their own, so this is another method that they'll use when they're trying to wean the patient off of a ventilator, to see how well the patient's actually breathing on their own. And those are just the kind of the basic settings you might see with a ventilator, whether it's volume targeted or pressure targeted, and how they assist. Just something to kind of file in the back of your mind so that you kind of understand if you're in a room and they talk about a patient being on one of these types of ventilator settings, you'll kind of be able to relate back to this course and understand somewhat what's going on with the patient and how it's working. As a nurse, you want to be aware of the complications that can occur as a result of mechanical ventilation. And there's a great description in your book about all the different ones, but there's some things I kind of want to point out to you. As far as cardiovascular complications, one of the most common cardiovascular complications of mechanical ventilation is hypotension. And usually this can occur immediately after intubation and the initiation of positive pressure ventilation, or it can occur anytime during the course of treatment. And what happens is the hypotension can be related to decreased cardiac output, hypovolemia, or the positive pressure delivered by the ventilator. I don't expect that you have to remember exactly how this happens, but you do want to make sure that when you have a patient on a mechanical ventilator, that you are watching for hypotension as a complication. As far as pulmonary complications, you may have heard the term barotrauma or volutrauma. If we're talking about barotrauma, that's damage to the lung tissue. If we damage lung tissue, that can lead to alveolar rupture. And that's because of the increased pressure resulting from that high ventilation pressure. So you've got to really be careful when you're setting the ventilator, or when respiratory is setting the ventilator, that we don't give too high a pressure that we cause that something called barotrauma. Okay, the lungs can only actually handle so much pressure without those alveoli rupturing. The second is called volutrauma. It's real similar to your barotrauma, but the lung damage is caused by increased volume that causes over-distension and hyperinflation of the alveoli. If you were to get barotrauma or volutrauma from a ventilator, you would hear that type of injury called a ventilator-induced lung injury or a ventilator-associated lung injury. And sometimes we have this happen without meaning to, because our patients who are in ALI or ARDS, a lot of times their lungs are stiff and they have reduced compliance, so they're not stretchy, and it takes a lot of pressure to fully inflate the lungs. So we have to set the inspiratory pressures kind of high, and that can lead to barotrauma or volutrauma. So we just have to kind of keep an eye on that and make sure that we're not causing more damage to the lungs that could actually lead to more of a respiratory failure. Gastrointestinal complications, abdominal distension. Sometimes being on a ventilator can cause the patient to swallow air, or air can actually get down the esophagus, and that can cause GI complications like abdominal distension. And if we notice that we're getting the GI distension or the abdominal distension, oftentimes you'll see the patient given an NG tube to facilitate with gastric decompression. So we might actually have an NG tube down to help with gastric decompression. If we had a nasal intubation going on, you might see the tube put down their mouth. We can actually put an oral gastrointestinal tube down. So what we're doing is basically trying to keep the air out of the stomach, to keep it decompressed so we don't have abdominal distension. The other thing that you might want to consider about having mechanical ventilation is that the body's under stress. And we talked about when the body goes under stress that we get increased hydrochloric acid in the stomach. So also your patients who are on mechanical ventilation will also have, will also be given things like Pepsid or an acid reducer IV to hopefully prevent gastric ulcers or GI bleeding as a direct complication of the stresses of having mechanical ventilation. Psychological complications, these are pretty simple: agitation, anxiety, and confusion. Depending on what setting they're on the ventilator, they might be sedated completely, but if they're not and they're awake and they've got a tube down, sometimes it can cause agitation and anxiety. You've got to constantly monitor your patient for these psychological complications and hopefully keep your patient as comfortable as possible. And last but not least, which should go up under pulmonary, but we set it aside by itself because it's so common, is that ventilator-associated pneumonia. Okay, this is pneumonia that develops more than 48 hours after intubation. It's actually the most common form of infection among patients in the ICU who get mechanical ventilation. And it's got a mortality rate of 20 to 50%. Keep in mind that when we intubate you, it interferes with the body's natural defenses. It impairs mucociliary clearance, it inhibits your cough, and it also facilitates microaspiration of bacteria. So you can see how this would open the patient up to just, hey, come on in, bacteria. Infection can set in. Some important things that the nurse can actually do to help prevent ventilator-associated pneumonia, or the healthcare team can do. Things like keeping the endotracheal tube cuff pressure above 20. Because if you think about the tube that's going in, I showed you in one of the previous slides in a previous lecture, there can be a cuff around that tube. And that cuff is to seal the airway off. If the tube pressure gets too low, then bacteria or secretions can actually go down into your lungs. So we want to keep the tube pressure high enough to prevent any leakage around into the respiratory tract. If a patient doesn't tolerate being extubated, we want to reintubate them quickly. And the concept behind this is that if they don't tolerate being extubated, they're not breathing effectively. So by putting the tube back down relatively quickly, we can set the pressures to make sure the patients are breathing effectively. Keep the head of the bed elevated, especially in patients who are getting enteral feedings. We're trying to prevent aspiration. Okay. Provide oral care every 2 to 4 hours and as needed. Remember, one of the dirtiest places on our bodies, our mouth, that's where bacteria are. And if we don't have the natural defenses to block the saliva or the bacteria from getting down our airway, then we have to make sure that we keep as much bacteria out of our mouth as possible. Pay attention to infection control measures, hand washing, and wearing gloves. If there's condensation in the ventilator tubing, we want to get it out of there. We know that warm, moist areas harvest bacteria, so we want to make sure that any kind of condensation that's in our ventilator tubing, we get it out. Okay. If possible, we try not to put our endotracheal or tubes through the nose. Okay, it's a little more dangerous because of the fact that we still have the airway open, and we do know that the nose tends to harbor more bacteria, especially whenever the patient's breathing in. Now, we know the mouth is full of bacteria, but when we put the tube in through the nose, sometimes we actually push bacteria down in from the sinuses. So we want to be very careful on that. And then the most obvious is try to reduce how long the patient's on mechanical ventilation. Okay? There's a lot of things we can do to hopefully prevent ventilator-associated pneumonia. And the list of the nursing interventions that you can do are listed on page 812 in your textbook. Oftentimes, your ventilated patient will have a chest tube. And there's two kinds of chest tubes that you could see. The first is the pleural, and the pleural is inserted into the pleural space, and it's there to get rid of any kind of air or blood and allow the lung to re-expand. So you might see this with a patient with a pneumothorax or a collapsed lung, where we need to open up that space for the lung to be able to re-inflate. A mediastinal is done in the mediastinal space, and it's usually done after some type of a thoracic surgery or a heart surgery, and it's to prevent fluid from building up in that space that would be exerting pressure on the heart. And I know that seems to be sometimes a cardiac problem when we talk about mediastinal, but with the pleural, it's directly related to lung disorders. And we put it in this section just to kind of introduce you to them, because as a nurse, it's up to you to know how to assess a chest tube. Make sure that with a chest tube, that the tubes are patent and they're draining freely. You can see in the bottom picture there's a drainage system down there. When you have a pleural tube, it's connected to an underwater seal drainage or to a one-way valve. And what's going to do then is, because of the water, it's going to allow air to exit the chest, but it's going to prevent air from entering back into the chest. It's kind of like the concept of putting a straw in a glass of water. You can blow and get air out of your mouth, but you can't suck back in and expect to get air back because that water's sealed. So as the air is being pulled out of the pleural space, you'll see bubbling in this chamber. On the other hand, the mediastinal tube has no titling because it's located in the mediastinal space and not the pleural space. Usually these tubes will drain blood or other kinds of fluids. But either way, what's important with these tubes is that they're patent and they're draining freely, and that you never clamp off a tube. They're there for a reason to drain, whether it's air, whether it's fluid, whether it's blood. They're there to drain, so never clamp a tube. Sometimes as a nurse, you'll be responsible for helping with the insertion of a chest tube, and you'll need to make sure you know what supplies to get. Usually it comes in a prepackaged chest tube insertion kit. And pleural chest tubes are commonly put in at the bedside, whereas your mediastinal are usually put in the OR because they're usually a direct link to a thoracic or cardiac surgery. But when you go to the hospital and you become a nurse, and if you see that you're going to be involved with chest tube placement, you'll want to know where your supplies are and make sure you understand the procedure. You're not going to be doing them yourself, but you want to understand the procedure enough to know how to give safe and competent care during the insertion and while the chest tube is in place. Another nursing intervention with mechanical ventilation is that nutrition. We said that when the patient's got a tube down, they can't take food in themselves. So we got to make sure that we're looking at our patient's nutritional needs. And in this case, we're talking about enteral or oral gastric feeding tubes are preferred. Finally, let's not forget about communication and sleep when we're talking about mechanical ventilation. If a chest tube is there, explain why the chest tube is necessary. So as a nurse, you need to understand your pathophysiology. If a patient's family comes in, or even if the patient is awake enough to know that they're getting ready to get a chest tube, they say, well, why is the chest tube being put in? You want to know how to respond. You need to know what type of chest tube it is. For example, we said if it was the mediastinal, if they're going to come back with a chest tube because we want to relieve the pressure in that space it could put pressure on the heart. If it's done as a pleural, it may be because the patient had a pneumothorax. Okay, and what that chest tube that is going to do is help decompress that lung to prevent further complications. It's going to actually open that space up so the lung can expand fully. It's not that the chest tube is going to help them breathe easier. The ventilator is going to do that. The ventilator is going to do the work of breathing. But the chest tube is going to allow the lung to fully expand. So it's going to decompress the lung so the lung can expand so the ventilator can push the air in. Okay, it's not elective. The patient didn't decide to do it. Okay, so you just kind of want to make sure you understand why to explain it, because that could be another very anxiety-inducing procedure for the patient and the family. Is they've already got a tube down their throat, and now we're putting a hole in and putting a chest tube in. Also, with communication and sleep, make sure that you assess your patient's ability to communicate. Sometimes the patient's not completely asleep while they're on a ventilator, but their airway's been blocked. As far as using the intubation procedures or even external positive pressure, make sure you assess your patient's ability to communicate with you and make arrangements, whether it's a whiteboard to write on, or if they have a trach, they can plug the trach tube and talk. And then one thing we forget about in the hospital is making sure our patients get some sleep. We've got so many things going on with labs and medications and assessments and family that try to make sure you arrange for some periods of uninterrupted rest. There used to be an old joke in the hospital about if you want to get some sleep, you got to go home to sleep. When you come to the hospital, you're not going to get any rest. These patients need their rest to be able to heal. So make sure you arrange for periods of uninterrupted rest for your patient on mechanical ventilation. We said that one of the ways we can help prevent ventilator-associated pneumonia is keeping our patient on the ventilator for as little time as possible. Okay? But that means we have to wean the patient from mechanical ventilation. More often than not, patients are not just going to be extubated and taken off mechanical ventilation overnight. It usually takes a little while to assess the patient's ability to breathe. So when we're talking about taking our patient off of mechanical ventilation, we want to weigh the benefits. We also want to look at the risks of early extubation. Is the patient going to be able to function on their own? What are the risks? There's a lot of different weaning methods. I don't want to go through all of them, and I'm not expecting you to understand all of them right now. It's a little bit above where you need to be as a new nurse. But understand that there's different ways that they're going to wean patients off. And you know that just simply by looking at the different types of methods that we talked about earlier. We talked about the volume targeted modes and the pressure targeted modes, about how many let the patient breathe on their own with just assisting, or which ones breathe all together for the patient. So there's different ways that we can actually bring it down and wean the patient off. During the weaning process, you definitely want to be monitoring your patient. We need to be watching for changes in blood pressure. We need to be watching for changes in oxygen saturation. Watch for signs of hypoxia. Watch for signs of agitation in your patient. Keep an eye on the ABG levels. Sometimes patients are taken off of mechanical ventilation and they get tired after being off the ventilator, because now the body's actually having to do the work and breathe on its own. And they can get so tired they have to be put back on a mechanical ventilation because their body just can't sustain. But successfully getting a patient off of a ventilator is very important for the patient's recovery, because we know that the longer they're on the ventilator, the more likely they are to have ventilator-associated pneumonia, the more likely they are to have complications that we talked about, like hypotension, like pulmonary complications, the GI complications. The body can become resistant or come dependent on the mechanical ventilation, and it loses its ability to breathe on its own. So trying to get them off as early as possible and is important to their recovery. That's why folks that try to get you off a ventilator relatively quickly, they say, the longer you're on there, the less likely you are to come off. And finally, we'll talk about non-invasive positive pressure ventilation. And this is what we talked about a little bit when we talked about upper respiratory and lower respiratory disorders, about your CPAP and your BiPAP. Okay, there's a lot of uses, and the success varies depending on how it's used and what it's used for. Depending on what it's used for, you may require continuous monitoring devices. This can actually be used for example, sleep apnea, if you've got hypoventilation for being overweight. It could be used for your patient who's got a do not intubate order but really should be intubated. We can use this to give them additional respiratory support. The goal is to reduce the workload of breathing, improve alveolar ventilation, and improve gas exchange. With this, it's important to educate the patient on what it's being used for, when to use it. There's a lot of different things as far as what to use in it. For example, if it's got to have some type of humidification, so you want them to use distilled water. We know that non-distilled water could potentially have bacteria in it, so we don't want the bacteria to be inhaled into the lungs. We want to talk to the patient about, are they a nose breather or are they a mouth breather, because your non-invasive positive pressure can be done with a nasal mask, it can be done through nasal prongs, or it can be done through a face mask. They find that the face mask itself is the more beneficial, or the more widely used, because most of your patients who need this are mouth breathers. When it comes to management, it's going to be multidisciplinary. It's oftentimes going to be a combination of a primary care doctor, a respiratory doctor, and we even have doctors that specialize in sleep disorders or obesity. So we're going to do a multidisciplinary collaborative management. You also may be using this non-invasive positive pressure when a patient's coming off of mechanical ventilation, but they don't quite have the ability to support their breathing completely on their own. Remember, if they've been on mechanical ventilation for a long period of time, their system may have gotten weak because it was relying on the mechanical ventilation to do the work of the breathing. So these non-invasive positive pressure ventilators or ventilation systems can actually help reduce the workload of breathing. When it comes to nursing management, we said that this can help prevent a patient from being intubated, but they do require continuous monitoring. One thing we have to be careful with is that a patient who's got a mask on that's constantly blowing air in is at risk for aspiration, because if they were to vomit or get fluids in their mouth or saliva, the air could potentially push it down the airway. We also want to be careful about facial trauma. If a mask is on and they bump into something, Or if the mask is just too tight, it can cause skin breakdown. Okay. Abdominal distension kind of goes along with what we talked about with the invasive ventilation. It can push air into the stomach and cause abdominal distension. And there were two kinds that you probably have heard of when it comes to non-invasive positive pressure. There's CPAP and there's BiPAP. Your CPAP is your continuous positive pressure, and your BiPAP is pressure limited, which means that with CPAP, it's going to blow constant pressure during inspiration and expiration. And the pressure is going to be equal during inspiration and expiration, so one pressure setting. A BiPAP is pressure limited, and basically you can set the inspiratory pressure and the expiratory pressure how you want them. So they can be separate. So you may have more inspiratory pressure, less expiratory pressure, or vice versa. And that's just simply what CPAP and BiPAP means. One is going to have the same pressure in and out, and one can be set differently. I want to conclude this lecture by simply reminding you to take into consideration our gerontological population. Our older folks are predisposed to respiratory failure. They've got a lot of other things that may be going on in their body. Their lungs are not as compliant as they used to be, and sometimes they just don't rebound from respiratory disorders as fast as the younger population does. So keep your eyes on these patients. They need to be approached carefully. You need to pay a lot of attention to their signs and symptoms. For example, when a patient is elderly and they exhibit signs of dementia, we often think it's related to pathological changes as far as aging, when it really might be a respiratory complication. So just pay special attention to your gerontology patients and realize that they're a little more fragile and need a little bit more nursing support.